So let's dive right into breaking down what the different parts of the course are. We're starting today with this intro module, which is an overall what is IBD and how do we think about it and approach it kind of talk. Uh, and then we'll get into labs and imaging, understanding the general menu of what labs, blood tests and stool tests, and what types of imaging, ultrasound, MRI, CT, all that kind of thing, are generally used in IBD. Then we'll talk about diet, which I call the foundation of IBD treatment, unless it isn't, because diet can be amazing, but it is not for everybody at every moment in time. We'll talk about prescription therapies, of course, and then supplements. There are so many supplements, and we try and take the top dozen that are worth talking about in detail. Herbal medicines, there are some amazing herbal allies out there for people with inflammatory bowel disease. Microbial medicines, so we're talking about probiotics, and we're talking about prebiotics, and we're talking about fecal transplant a lot. We talk about helminthic therapy. If you're not familiar with this, it's also called worm therapy. Super intriguing for IBD. We've used it a fair amount between the three of us. And then we end up talking about the basics. Sleep and exercise and smoking and air quality and all those types of things. So here I am giving this intro course, and Dr. Sheeler will do the next module about labs and imaging. And then Dr. Bustamante, nutritionist, will do the diet module. Then Dr. Sheeler for drug therapies, and me for supplements, Dr. Bustamante for herbs, and you'll end up getting 3 modules from each of us before the end of the course. So I've talked about us as clinicians and educators. I've talked about how to use the course, and now is this part that I'm super excited about, where I get to really start talking about IBD, what it is, and how it happens. So your introduction to inflammatory bowel disease is going to start out with some anatomy and physiology, some pathology, and some immunology. So I taught anatomy and physiology for years, and just to explain what that means, anatomy is the discussion of the structure of the body, the physical things that make us up. And physiology is the discussion of the function, how things work in the body. That's anatomy and physiology. I loved teaching anatomy and physiology for years, and I'm going to be doing some specific IBD anatomy and physiology for you today. Pathology is the study of how disease happens, what happens when things go wrong, and we'll be talking about that today. And immunology just means how is the immune system involved. So your introduction to IBD starts out with an introduction to anatomy and physiology. Okay, so let's start at the smallest levels. These are called the levels of organization, from the smallest bits that make up a person until the person herself. And so it starts on the atomic level. And we're not going to be talking about the atomic level today. That's physics. That's more detail than you need for medicine. They say, why can't you trust atoms? It's because they make up everything. But we will talk a little bit about the next level up. So atoms make up molecules, and we'll be talking about things at the molecular level. Here's an example. This is butyrate, or butyric acid. It's a short chain fatty acid, and here's the acid part, and here is the short chain part. So very short chain, and we'll be talking about that in the supplement section, butyrate. And butyrate is named butyrate because it was originally found in butter from free-range cows. So cows that have healthy gut bacteria, just like we do, the healthy gut bacteria produce butyrate, this short-chain fatty acid, and sends these messages of safety, which leads to reduced inflammation. So that's butyrate. That's an example of a molecule. And we talk about butyrate, that's the example of us talking about things at a molecular level. So atoms make up molecules, and molecules make up cells. So the next level up is the cellular level. And here's a picture, a 3D illustration of a cell with the nucleus at the center and the phospholipid bilayer that makes up the cell membrane. And one cool thing, here's like a mitochondria, and you might remember mitochondria, the powerhouse of the cell from middle school and high school or even college biology. Okay, yep, here's the plasma membrane that I just mentioned, the phospholipid bilayer on the outside. Here's the nucleus at the center that contains all the instructions for how the cell works. And yeah, this is the cool part about butyrate. This short-chain fatty acid is so short, it's able to diffuse right through the plasma membrane and go to the nucleus. And because it comes from happy, healthy bacteria, it is able to hit the nucleus, and the nucleus says, oh, a bunch of butyrate around. Well, we should express genes that we would express in safety times, not inflammatory genes. We're not going to express the inflammatory genes that we need to express when there's a lot of pathogenic or dysbiotic or unhealthy bacteria around. Let's be safe. It appears that we live in a safe world. So that's a cool example of talking about how different supplements work, talking at the molecular level and at the cellular level. The next level up is the tissue level. And quick anatomy and physiology lesson, you don't need to memorize this, there's no test, but there are 4 types of tissues. Epithelial tissue is our connective tissue, and how that relates to IBD is like the lining of the intestines, which I'll talk about today and we'll talk about in some other sections. The lining of the intestines are made up of epithelial tissue. Muscle tissue, you might not think has to do with IBD too much, but there's 3 types of muscle tissue. There's skeletal muscle, okay, that's our biceps. There's cardiac muscle, that's your heart. And then there's smooth muscle. And smooth muscle is how we do peristalsis. This is how the smooth muscle of your intestines contracts and moves a bolus of food, and later partially digested food that we call chyme, and later at the very end feces. That's how all of that moves through the small and large intestine, is through the action of smooth muscle. Connective tissue is this kind of funky catch-all category that has a lot of tissues in it, including bone is a connective tissue, blood, fat, tendons, and ligaments. These are all connective tissues. And blood is one we're going to talk about. We're going to talk about red blood cells and how they carry oxygen and how people can get really fatigued if they've lost so much red blood cell through bleeding in IBD. And we're going to talk a bunch about white blood cells and how those work in IBD as well. And nervous tissue, that's like the brain, the spinal cords, the cranial nerves, peripheral nerves, and the enteric nervous system. So we will talk about a little bit, I think, in this course about the vagus nerve, cranial nerve 10, amazing nerve. And we'll talk about the enteric nervous system, which is so complete onto itself that you can remove intestines from a living being. And that enteric nervous system will keep on doing its digestive thing, even separate from the brain and spinal cord. So when we talk about the tissue level, this is what we're talking about, like the lining of the intestines, the smooth muscles that make peristalsis happen, cranial nerves and enteric nerves and blood, stuff like that. Those are all tissues. And then the organ system level, I'm going to talk about these a little bit together, but here are different organs in the digestive organ system. The small intestine and the large intestine are the 2 big ones to talk about in inflammatory bowel disease. And as we'll see in a couple of slides, in Crohn's disease, the small intestine and or large intestine can be affected. And in ulcerative colitis, in terms of intestines, it's just the large intestine. But Crohn's can actually affect you anywhere from the mouth to the anus. Any of that tissue can be involved, and I think I've seen it be involved in every single spot in my Crohn's patients in the past. And we'll also talk about the liver that can be relevant, and about the gallbladder. And I do want to point out a bit of terminology here. So when we talk about the left colon or left-sided colitis, that's what we're talking about here, is the very end of the colon. Food goes in through the mouth, you swallow it through the esophagus, it goes into the stomach, and then it goes into the small intestine. It goes around and around and around the different parts of the small intestine until it gets to the end of the small intestine, which is called the ileum, and then it goes into the large intestine. And the ascending large intestine, the transverse large intestine, the descending large intestine, the sigmoid large intestine or colon, and then the rectum at the very end. So those are the parts of the digestive tract. And the most common type of colitis, in ulcerative colitis, is a left-sided colitis, which means it's affecting the rectum, the sigmoid, and the descending colon here. So that's what we mean. And brief note, originally in this intro course, I had a whole huge section on vocabulary, and my colleagues told me that that section was semi-mind-numbingly boring. So I still think it's important. So we made a handout of vocabulary for you that can help you follow along through this course and the other courses. We try to make things really accessible, but we do use some scientific and niche kind of terminology. So the vocabulary handout might help. If you want to be extra nerdy and review it, I did make a separate video reviewing the vocabulary. Okay, and then we're going to talk about how things affect you at the organism level as well. So I'm going to spend the next few slides talking about how we get affected at some of these different levels. So, okay, we're going to talk about things on the tissue level by kind of starting at an organ level. So if this is the intestines, okay, the part in the middle that food goes through is called the lumen. That's just the term for the inside of the intestinal tract. And so food goes through the lumen, and in this illustration out here is outside of the intestines, in your abdominal cavity. And food should never belong there. That could be infectious and very, very harmful. So food goes through the intestinal tract. And when we're talking about tissues, I'm going to zoom in on the tissue level in the next slide. And actually, there's like a mucin layer that kind of is on the very outside. That's what these squiggles are supposed to represent. And then there's some what's called perivisceral fat on the outside of the tissue. So I want to just talk for a second about my daughter. I have a daughter who's starting at college as a freshman in college this fall, and her goal is to be a medical illustrator. So I asked her to make an illustration of digestive cells and how they're affected by inflammatory bowel disease. So she was kind enough to make this quick illustration of the different tissue levels, which I have labeled here. So I mentioned in here is the lumen, and as we get deeper in the layers of tissue, they have different names that are illustrated here. And like I said, on the outside is the perivisceral fat layer. So we've got the lumen, and then there's some mucin covering the entire inside. And you go deeper and you have what's called the mucosal layer. So you'll hear us use this term when we talk about the intestinal mucosa. And then deeper you get the submucosa. And then you have the muscularis, that's the muscular layer that I mentioned, contracts to move things along through peristalsis. And on the outside you have the serosa and then the perivisceral fat. And what I'm trying to illustrate here by this drawing, so you know about how the pathologies differ, is you get these inflammatory ulcerations in ulcerative colitis that can go down deep and cause pain, redness, bleeding from this layer because this is very well innervated. And with Crohn's disease, those ulcerations go even deeper. And sometimes they can even go so deep that they bust through the serosa and the perivisceral fat, and they bust through intestinal tissue, and you have what's called a perforation. So food from the lumen can go all the way through that ulceration into the abdominal cavity where food should never be, and that can be very dangerous. So ulcerations can go deep in ulcerative colitis, and they don't always, but can go even deeper for patients with Crohn's disease. Okay, I want to talk about more differences between Crohn's disease and ulcerative colitis at these different levels. And to help us here, I've got this other little illustration of the intestines right here. So Crohn's disease can be in the small intestine or in the large intestine. And 30% of the time, it's just in the small intestine. Usually in the ileum, the last part of the small intestine. 50% of the time, it's in the small intestine and the large intestine, and 20% of the time, it's just in the large intestine or the colon, and that's when we call it Crohn's colitis. If it's just here in the ileum, we call it Crohn's ileitis, and if it's in both combined, we call it Crohn's ileocolitis. So yeah, usually in the small intestine, in the last part of the ileum, the terminal ileum, and that is located right here. Okay. And yeah, when it's located just in the large intestine, just in the colon, you have almost double the risk of something called primary sclerosing cholangitis, which is usually more common in ulcerative colitis, and I'm going to talk about that later. Okay, so ulcerative colitis, just in the large intestine. And in terms of the tissue level, Crohn's has patchy inflammation. They're called skip lesions, where you can have a little inflammation here, and then a bunch of healthy tissue, and a little inflammation here, and a bunch of healthy tissue, and then a little inflammation here, etc. Ulcerative colitis is contiguous, all in a row, no skip lesions. Crohn's can be anywhere, as I mentioned before, from mouth to anus, whereas ulcerative colitis almost always starts in the rectum, which we call ulcerative proctitis, and then moves contiguously upwards until sometimes it gets to the whole colon, and that's what we call pancolitis. And as you saw in the last slide, Crohn's inflammation can be what's called transmural, extending so deep it can cause an abscess, it can cause a fistula, which is an inflammatory tract, or like an inflammatory tunnel that can leave the intestines and go to other places. I'll talk about this later, but there can be perianal fistulas, which go from usually the large intestine to the area right next to the anus. They can go to other organs. There can be inflammatory fistulae or tunnels between the small intestine and the large intestine, or between the intestines and the bladder or the vagina or other places. I'll talk about that more later. So fistulae, pretty common in Crohn's, all unheard of in ulcerative colitis. Basically never happened. Ulcerative colitis, not this deep transmural inflammation. The inflammation is only in the mucosa and the submucosa. And for Crohn's, at the organism level, pain is the most common symptom. It can be anywhere, but more often right-sided, which makes sense because as you're looking at this on your left, this is the patient's right, because mirror image, they reverse you. So the right side is where we see the terminal ileum here. So pain is more often right-sided, often diarrhea, not always, but often diarrhea and maybe bloody. Fatigue and weight loss are super common. And like I said, there can be strictures or inflammatory narrowing, which you know if you watch the vocabulary section. There can be abscesses, which are like a walled off area of inflammation. And there can be fistulae, which are these inflammatory tunnels. For ulcerative colitis, diarrhea is the most common symptom, often bloody or mucousy discharge. Urgency, or it can even be so urgent that you can't make it all the way to the bathroom, and you can have fecal incontinence. And it may have abdominal pain, not as common with Crohn's, but I've seen plenty of abdominal pain. And it's often left-sided. Why left-sided? Well, as you're looking at what we call the left colon, that's on your right, as you're looking at this image here on the right side, that's left-sided colitis, and that's the most common kind. So that's why it's more often left-sided pain, but of course it can be anywhere. So this slide's kind of complicated, but I think it's worth it to be able to talk about prevalence. So in the United States, 3 out of every 1,000 people have Crohn's disease, and 3.8 people per 1,000 have ulcerative colitis, and another 0.4 people per 1,000 have what's called indeterminate colitis, otherwise known as IBD unspecified. So a certain number of times we can see there's autoimmune inflammation in the colon, and we look at the tissues under a microscope and we see how it presents, and it's not totally clear if it is Crohn's colitis or ulcerative colitis. So then we call it indeterminate colitis or IBD unspecified. And we usually treat it more like ulcerative colitis. So this is a look at the United States and Japan, how prevalence has changed over the course of a decade. So this study looked at IBD prevalence from 2010 to 2019. And the United States in that decade, it went from 158 cases per 100,000 people to 233 cases per 100,000 people. So that's a 50% increase in a decade. And in Japan, it went from 5 cases per 100,000 to 98 per 100,000. So 20 times higher over the course of a decade. So this is very common around the world in industrialized countries, and in newly industrial countries, we see rates of inflammatory bowel disease really, really increasing over the past 10, 20, 30 years in most places. So I want to talk about things that increase risk. Urban living increases risk. An unhealthy diet increases risk. Having antibiotics early in life increases risk. and having leaky gut increases risk. I'm going to talk about some of these things in more depth later. And the things that decrease risk include breastfeeding when you're a baby, having H. pylori. We think of H. pylori as a bad guy, and sometimes it is, but sometimes it's not. And having enough vitamin D around. These are all things that decrease risk of inflammatory bowel disease. I'll talk about vitamin D ad nauseum in the supplements section. Some other things here, some other risk factors that are specific to ulcerative colitis or Crohn's. For ulcerative colitis, periodontitis, gum inflammation, looks like it probably increases risk of ulcerative colitis, but not Crohn's, probably. Smoking tobacco doubles your risk of Crohn's disease, but doesn't seem to increase risk of ulcerative colitis at all. And in fact, some recent studies show it may be protective. In the lifestyle section, Dr. Bustamante talks at length about tobacco and how overall it is not good for your quality of life or length of life to smoke tobacco, even if you have ulcerative colitis. But this can make us cautious about the rate at which somebody quits if they are in a flare or not. So this is really valuable information to know. Having an appendectomy, so like when you get appendicitis and your appendix is removed, having an appendectomy when you're young decreases the risk of getting ulcerative colitis by about 60%. And there was a study just published in 2025 showing that they randomized people with ulcerative colitis that was in remission to either get an appendectomy or not. And if you got an appendectomy, you were substantially more likely to remain in remission a year later, which I think is fascinating. But for Crohn's disease, having an appendectomy does not change your risk of getting Crohn's, or maybe some studies show even increases your risk a little bit. So ulcerative colitis and Crohn's are very similar in some ways. That's why we're having a course on the two combined, but there are some very important differences in what are risk factors for them and how they're treated, and we'll talk about that. Other risk factors that are common to both of these, there are a ton, but some important ones to mention are that regular use of the following things increases your risk of inflammatory bowel disease. One is oral contraceptives. Some early studies showed that ulcerative colitis oral contraceptive use tripled your risk of ulcerative colitis and didn't affect your risk of Crohn's. But more recent studies show that there's probably a 30% increased risk in both of them, more or less, if you are a regular user of oral contraceptives. Proton pump inhibitors. So these are the strongest acid blocker in your stomach. H2 blockers are less strong and do have some risk, but less risk. But proton pump inhibitors have a statistically significant 40% increase in your relative risk for IBD. And I'm using these terms here because I'm about to go through what it means for something to be statistically significant and what it means to have a relative risk. So I'm using this long, somewhat technical language because it's important to talk about, and I'm going to explain what that means in just a moment. And another one is the use of antibiotics. Statistically significant 30 to 100% increase in your relative risk for IBD, depending on if you've had 1 or 2 or 3 or more courses of antibiotics in your young life. Leaky gut. This is an interesting one. So this increases your risk of inflammatory bowel disease. And actually, it's cool to know about that if you have inflammatory bowel disease and you have relatives who don't have inflammatory bowel disease, they can test themselves for leaky gut. And the ones who have leaky gut are substantially more likely to develop inflammatory bowel disease in the future. So you might be able to cut it off at the pass if you have a relative who doesn't have IBD and they're tested and they have leaky gut. To work on fixing their leaky gut may prevent IBD from ever rearing its ugly head, its ugly leaky head. Okay, so I want to talk about complications and extraintestinal manifestations. This is a big slide with lots of numbers on it, and basically there are a ton of different things that can co-occur with the intestinal inflammation of IBD. And you have different risks of getting them, depending on if you have ulcerative colitis or Crohn's, or sometimes you have a range of getting them with IBD as a group. And some of these things are super common. Osteoporosis, 10 to 15% of people get it. I'm going to talk about this more later. Arthropathy or arthritis, so that's joint swelling and pain, significantly increased rates in ulcerative colitis and Crohn's. And anemia, super common. Of course, you're losing blood in your stool very often, so you're more likely to get anemic. And some of these things are super dangerous. So there are ophthalmic or ocular eye-related extraintestinal complications. Extraintestinal just meaning outside the intestines, like uveitis or episcleritis. And if you're having that inflammation, which a substantial number of people with IBD do experience, 2 to 6 or even 7%, you can experience permanent visual damage unless you treat that rapidly, usually with topical steroids. Fistulae, I talked about what those are, very rare in ulcerative colitis, but in 20 years of Crohn's disease, about half of people with Crohn's are going to experience a fistula. Primary sclerosing cholangitis, I mentioned that before. That is affecting the biliary tree, more common in ulcerative colitis or in people with Crohn's, colitis especially. And of course, a very dangerous manifestation, colorectal cancer. 8% of people with ulcerative colitis will experience a colorectal cancer diagnosis by 20 years after they've been diagnosed. And by 30 years after, that goes up even higher, substantially higher. So some of these things are very common and some of these things are very dangerous. And we're going to talk in this course about how to treat some of these things when they come up and how to hopefully prevent some of these things before they even happen. I also want to take a moment and talk about validated scales. I mentioned earlier that one of the reasons that IBD is so quantifiable is that we have these validated scales. For 70 years or more, people have been asking these same sets of questions. And there are a bunch of different scales. I mentioned them at the end of this slide. But the one we use most commonly for ulcerative colitis is the Simple Clinical Colitis Activity Index, which asks about these questions. And the one that's we use most commonly for Crohn's is called the Harvey-Bradshaw, and it asks these questions. And we can use what score you get on the SCCAI or on the Harvey-Bradshaw. We can use what number you get from the answers to these questions. What's your overall well-being? How many times in 24 hours are you stooling? Are you stooling at night? Is there blood in stool? Is there abdominal pain, etc.? We can use the answers to these questions to help us determine, are you in remission? Do you have mildly active disease, moderately active disease, or severely active disease? And the Harvey-Bradshaw is good. There's another one called the Crohn's Disease Activity Index, which we like also, that also asks about weight loss and also asks about hematocrit. So we use Harvey-Bradshaw more often because when we order hematocrits or patients bring in their hematocrit, which is a blood test Dr. Sheila will talk about, we don't always have that data at the same time we have the answers to these questions. And here's how you determine if somebody is in remission or mild, moderately, or severely active with CDAI. And we love to use these scales to track severity. So there are apps you can use. There are different methods to track your answers to these questions. And if you're working with us, we may help you have access to certain apps to track what your severity levels are. And I mentioned I would talk about some other scales. Here are a few. There are a few different Mayo scores, the partial Mayo, the endoscopic Mayo. There's one called the True Love and Wit score. For quality of life, there's the IBDQ scale, which we do ask those questions sometimes. And then there are different pediatric scales, the Pediatric Ulcerative Colitis Activity Index and the Pediatric Crohn's Disease Activity Index. And we use these ones for our pediatric patients, of course.